Welcome. This video demonstrates the equipment and steps required to successfully intubate through a supraglottic airway device, while also providing continuous airway support. Airway support refers to the ability to connect to an anesthesia circuit and provide respiratory support using either CPAP, pressure support, or controlled ventilation, while also allowing the provider to administer inhalation agents. This method allows the provider ample time to successfully intubate even if adjustments are required during the process. We will begin with the necessary equipment, which starts with the appropriately sized flexible fiber scope relative to the chosen tracheal tube. A gap of approximately 0.8 millimeters between the internal diameter of the tracheal tube and the outer diameter of the fiber scope is desired. The larger the gap, the more effective for respiratory support. As this gap gets smaller, the provider needs to be aware of the potential for air trapping and barotrauma. If a fiber scope is not absolutely available, then at a minimum, monitoring the end-tidal carbon dioxide level and/or the breath sounds as the tracheal tube is advanced are essential. Without the fiberscope, success rate will drop dramatically. Next, a supraglottic airway device that is specifically designed as an intubation conduit is strongly recommended. These specialized devices have airway conduits that are shorter in length yet wider in diameter. The shorter length allows the tracheal tube to be placed into the correct position in the trachea while still leaving the circuit adapter outside the device. This permits continuous connection to the circuit as the tracheal tube is advanced and positioned in the trachea. The shorter the conduit length also lets the provider grab the tracheal tube in the mouth as the supraglottic device is removed over the tracheal tube without needing to advance the tracheal tube further into the airway. The larger diameter of the airway conduit, together with removing the 15 millimeter circuit connector, will pass a lubricated pilot balloon even in a neonatal-sized supraglottic airway device. Manufacturers state that their product will allow intubation, but most are not specifically designed with such described advantages. Always perform a simulated intubation sequence with your equipment before trying in a patient to verify the specific steps needed and how to address any difficulties. A tracheal tube and syringe are required. The syringe is for the cuff tracheal tube and, if needed, the supraglottic airway device. The tracheal tube can be preloaded into the supraglottic device and placed as a single unit into a patient where this intubation technique is pre-planned, or the tube can be loaded after a supraglottic device is placed, such as during a rescue intubation. The tracheal tube should be placed from halfway to nearly the end of the conduit, allowing some of the conduit to be visible at the fiberscopic exits. As the fiberscope exits the tracheal tube, provides the user with a better perspective of the patient's anatomy, and if needed, makes it easier to adjust the supraglottic airway device to better align with the larynx. Ventilation and seal should be verified before attempting intubation. As the conduit is large enough to pass a pilot balloon, which is similar in size to a 5.5 millimeter inner diameter tracheal tube, most pediatric patients will require that the tracheal tube has its cuff fully inflated within the airway conduit of the supraglottic airway to effectively seal the system. A triple port swivel adapter is used to attach the tracheal tube and the circuit while also providing a port for the fiberscope. As the fiberscope ports on these adapters are designed for adult-sized fiberscopes, adding durable tape over the port with a pre-cut yet tight slit for the pediatric fiberscope will help prevent a large leak from the closed circuit. As used here, thicker tape is preferred over tegaderm-like covering, as the latter will tend to stretch more easily and eventually result in a circuit leak. Finally, a tracheal tube holder, better referred to as a stabilizer, is required to stabilize the tube in position as a supraglottic device is removed. Recall that supraglottic airway devices are designed for intubation, such as the AirQ in this video. The tube is already in proper position in the trachea, such that the tube holder is used to stabilize the tube as the airway device is removed and not to advance it further into the trachea. We prefer laryngeal forceps, also called alligator forceps, as it offers a firm grasp of the tracheal tube that is manually controlled by the provider. This equipment may be obtained from our otolaryngology colleagues. Our next preferred method is using two tracheal tubes. The stabilizing tube should be uncuffed and can be the same size as the intubating tube. Other methods include using specialized stabilizers devised for this purpose, such as these stabilizers made by the AirQ company, which comes in 3 sizes. The 2 largest ones are shown here. Another key aspect for the stabilizer is that the tracheal tube must be grasped in the oral cavity before stabilizer and the pilot balloon will get entrapped within the conduit, necessitating an in-block removal of everything from the patient. One way around this entrapment issue is by using two tracheal tubes. For this to work, the stabilizing tube is cut just short of the length of the pilot cuff line as shown here. When cutting the stabilizing tube, discard the portion with the Murphy's eye and connect the part with the circuit adapter, as this allows the same size tubes to be combined, enabling the maximal space between the tubes and the fibroscope. During the manufacturing process of the tracheal tube, the placement of the 15mm circuit connector onto the tracheal tube results in dilating that small section, permitting a same-size tracheal tube to be inserted. Discarding the Murphy's eye portion of the stabilizing tube permits two-tube junction to remain cylindrical. Then, the passage of the pilot balloon through the conduit is possible without the need to first separate the two tracheal tubes. This shortened extra tube still permits continuous airway support during the removal of the supraglottic airway from the mouth. Once the device is removed from the mouth, then the circuit connector is removed from the tracheal tube extender. This enables complete removal of the supraglottic airway device over both tubes, as the pilot balloon is now positioned just above the stabilizing tube as they travel through the conduit during removal. This shortened two tracheal tube method minimizes the circuit disconnect to as little as 5 seconds, which may be beneficial in our most at-risk patients with minimal cardiopulmonary reserve, such as patients with severe pulmonary hypertension. Large enough bougies, stylettes, or tube exchangers that can get wedged into the tracheal tube can be employed as stabilizers. However, these can get stuck in the tube, making it difficult to remove, so are not recommended. Adequate lubrication is essential for both the tracheal tube and the pilot balloon. The pilot balloon must be well lubricated before pulling it through the airway conduit of the device. If difficulty is encountered while trying to pull the pilot balloon, it is better to push the pilot balloon through using whatever stabilizer was employed for the tracheal tube than pulling on the pilot cuff line with force, as the latter will more likely separate the pilot balloon from the pilot cuff line. Now that we better understand the equipment needed and the concepts involved, let's move on to an example of setting up and using this combination technique as narrated by Dr. Jamie Peyton with help from Dr. Bistra Vlassakova.
So we're now going to set up the air-Q laryngeal airway as if we were going to be intubating through it. So Bistra, she'll pick it up, disconnect the connection point, and then place the endotracheal into the device and have it so the tip is literally just at the tip of the bowl. And if you just pull that back a little bit, Bistra, so there we go, just there, and then inflate the cuff of the ET tube, and that now forms a seal within the lumen of the LMA, and then place the swivel adapter. Now this is now our supraglottic airway device. So here Bistra has the hybrid LMA and ET tube setup that we showed you earlier, and we're going to demonstrate how to intubate through the laryngeal mask airway whilst continually oxygenating and ventilating. So she has placed the ET tube LMA hybrid and is testing to make sure we can ventilate, and as you can see, we can ventilate. At this point, we need to perform the flexible bronchoscopic intubation through the swivel adapter and ET tube. So Pete is going to hand Bistra this. It's a two-person technique, so you need somebody else to assist you. Bistra will pass the flexible bronchoscope in through the ET tube and down to the carina. At this point, it is possible to continually oxygenate and ventilate the patient. We recommend doing it in paralyzed patients to prevent coughing and bucking. The idea is that if your LMA is seated in the correct place, you will find yourself directly on top of the larynx, which was the case here. So we're now at the carina. Your assistant will deflate the cuff of the endotracheal tube and then gently pass it through over the fiber optic scope. And at this stage, it's often common that the fiber optic scope is pushed into the right main bronchus. So Bistra kept control of that. She's going to slowly come out, looking for the tip of the tube. So there you go, we're not in too deep and we're not too far away. And if you come all the way out now, Bistra, you would then come on out, close off the hole and gently ventilate the patient, inflate the endotracheal tube cuff, and you now have a secure airway. At this stage, you can either leave the air-Q laryngeal airway in place or you can remove it. Okay, so now Bistra is going to disconnect from the ventilator, including the connection pieces, and she's going to stabilize the ET tube and slowly pull out the laryngeal airway. As she does that, Pete is going to grab the tube as soon as it appears in the mouth, and then Bistra removes the laryngeal forceps or the pushing device, stabilizing device, because it's possible to get the pilot balloon stuck beside it. So you need to remove your stabilizing device before you take out the tube. We're now going to hook up back to the ventilator. You would reassess your ability to ventilate in case something has happened. And then the other thing you now can do is check the position of the tip of your ET tube using your fiber optic scope or your high definition video bronchoscope. As you can see is what we're doing now.
You can also at this point check use ultrasound if you want to instead of fiber optic or auscultation.
Perfect. Thank you.
The advantages of this combination technique are numerous and include the ability to provide continuous oxygenation, ventilation support or controlled ventilation, video confirmation of the tracheal tube placement, as well as has 3 discrete points for patient reassessment to optimize the anesthetic depth, oxygenation, and ventilation of the patient. First, after placement of the supraglottic airway device. Second, after placement of the tracheal tube into the trachea. And last, after removal of the device over the tracheal tube. This technique also provides ample time for intubation and improves the alignment of the fibroscope's pathway into the trachea, making it easier to use the fibroscope. Most of these advantages are predicated on the ability to have an effective airway via the supraglottic airway device. All providers must also realize that no technique is 100% successful. Thus, backup plans and appropriate personnel are essential in any airway management plan. We hope that this has provided added insight and guidance on the combination technique of a flexible fibroscopic intubation via a supraglottic airway. Thank you.